Welcome to the Australian Dental Council Explainer podcast.
Glad to be here.
And just a quick note before we jump in. This content is purely educational and not a commercial endorsement of any kind.
Right, absolutely.
So today we are doing a deep dive specifically engineered for you. If you are an overseas trained dentist, an ADC candidate, a dental student, or an oral health therapist, this is your roadmap.
Yeah, this one is incredibly relevant for the exams.
Totally. We are unpacking case 1 from Odell's clinical problem solving in dentistry. It's about a high caries rate. And the scenario is you have a 17-year-old student sitting in your chair.
Okay, a teenager.
Right. And historically, he's been, almost completely caries-free his whole life.
A dream patient, basically.
Exactly.
Yeah.
But today he comes in and he presents with several massive new carious lesions. I mean, his lower right first molar is nonvital. It has a periapical abscess.
Wow, that's a massive shift.
It is. And we're going to break down the diagnostic challenges of this, the strict sequencing of treatment, clinical caries removal techniques, and the preventive management you need to implement.
It really is the ultimate clinical test because, before you even think about picking up a handpiece to fix that massive abscess, you have to understand why this happened so suddenly.
Right.
The presentation of caries in young patients has just fundamentally evolved over the last few decades.
Let's look at the anatomy of that evolution, actually. The source text points out that occlusal lesions, so cavities on the biting surfaces of the back teeth, they are the predominant form of decay in adolescents today.
Yeah, without a doubt.
But the immediate problem is that these lesions are, well, they're practically invisible.
They are. It's a huge diagnostic trap.
Like a clinician looks into the mouth, they see pristine white enamel on the biting surface, and they just assume the tooth is perfectly healthy.
And to understand why that happens, you have to look at the microanatomy of a tooth fissure and combine it with modern fluoride use.
Because fluoride is doing something tricky here.
Right. A fissure on a molar isn't just a shallow bowl. It's often like a microscopic canyon. The bristles of a toothbrush literally cannot fit inside to clean it.
Oh, wow. I didn't realize they were that deep.
Yeah. So decay doesn't start on the flat outer surface. It initiates deep down on the internal walls of those fissures.
And this is where fluoride plays that paradoxical role we read about.
Mm-hmm.
We think of fluoride as the ultimate protector, which, it is, but it actually masks the disease here.
Exactly. The fluoride ions wash over the top of the fissure, creating this super hard, highly remineralized outer shell right at the entrance.
So it's like a house with a reinforced steel roof, but it has termites in the foundation.
That is a perfect analogy, yes.
From the outside, the fluoride makes the roof look completely intact, but it's masking the structural collapse happening underneath.
Because underneath that pristine roof, bacteria are just trapped in the canyon. They produce acid, and the decay progresses downward into the softer dentine.
And the superficial enamel just stays put.
Yeah, it cavitates incredibly late in the disease process, if it even breaks at all.
Which is wild.
Yeah.
And that reinforced roof creates a secondary problem, right? It hides the decay from your x-rays.
It does. When you take a bite wing radiograph, you're looking for a dark, shattered area where the mineral density is gone. But enamel is so dense.
So when the x-ray hits the tooth, the thick, healthy enamel walls just absorb the beam.
Right. You get this bright white superimposition on the film that completely drowns out the small gray shadow of the decay underneath.
Unless the lesion is massive, the x-ray just looks normal.
Which leaves you in a really dangerous spot clinically. You can't trust your visual exam, and you can't entirely trust the bite wings.
So what's the protocol? What's the clinical rule of thumb here for someone taking the ADC exam?
The rule is if you find even a single small occlusal cavity in a second molar, your suspicion needs to instantly skyrocket.
You just assume the others are bad too.
Exactly. You must assume that other plits and fissures in the molars are also harboring hidden decay.
Okay, so you realize the extent of the damage. You've got hidden decay everywhere, plus that lower right first molar is non-vital and infected.
It's an overwhelming amount of work.
It is. You can't just start randomly placing permanent fillings. You need a strict sequence. The text breaks this down into 4 distinct phases, starting with the immediate phase.
Right. You have to manage the acute crisis first. You don't fix a broken arm while the patient is having a heart attack.
So you start with that lower right first molar.
Yes. You remove the gross decay, prepare an access cavity, and establish drainage for the pus.
And you irrigate with sodium hypochlorite?
Always. It's a potent antibacterial agent, and it dissolves the necrotic tissue. Then you place a temporary restoration.
Which makes sense. You can't leave a hollowed-out tooth open to the environment.
No, absolutely not. If they bite down on hard food, the tooth splinters and then it's completely unrestorable. Plus, the temporary filling prevents mesial drift.
Right, mesial drift, where the adjacent teeth start tilting forward into the empty space.
Exactly. And practically speaking, having that temporary buildup makes it physically possible to place a rubber dam later for the final root canal.
Wait, let me push back on this for a second. Considering this is a 17-year-old with such extensive damage to that first molar, why not just extract it and save the hassle?
It's tempting. And a casual patient might actually request that. But biologically, at 17, extracting a first molar is a massive decision.
Because of the space it leaves.
Yes, you cannot guarantee that a third molar will predictably erupt and perfectly fill that massive gap. If you pull it, the second molar tilts, the opposing upper molar drops down, and the entire bite collapses.
Oh, wow. So retention is the better long-term choice, even if the prognosis is guarded.
It acts as a critical space maintainer while you assess the rest of the mouth.
Okay, so the immediate fire is put out. Then we move to phase 2, the stabilization phase.
Right, where you address all those hidden cavities quadrant by quadrant.
You remove the caries and place temporary restorations in all the carious teeth. But why temporary? Why not just use permanent composite resin right then and there?
Time and moisture control. Composite resin is incredibly technique sensitive. It takes a lot of time to layer and cure perfectly.
And you're fighting a ticking clock with rampant decay.
Exactly. If you spend 2 hours perfectly sculpting one composite filling, the cavities on the other side of the mouth are actively burrowing into the nerve.
So what material do you use instead?
Glass ionomer cements, they're the workhorse here. They chemically bond to the dentine, tolerate moisture better, and they release fluoride.
So your goal isn't perfect aesthetics, your goal is just biological disease control.
You're hitting the pause button on the disease, sealing off the bacteria from their food source.
Which brings us to the actual tactile art of drilling during the stabilization phase. Because you have to know exactly how much tissue to remove.
This is a huge emphasis on the ADC exam. The rules change depending on where you are in the tooth.
Let's talk about the amelodentinal junction, the ADJ.
The rule there is absolute. It must be perfectly clean. All softened carious tissue has to be removed.
Otherwise, the enamel roof is unsupported and the filling leaks. But there's a distinction here, right? Stained but hard dentine can stay.
Yes. Color is a terrible indicator of active disease. If it's dark brown but feels as hard as glass, it's not actively decaying. Hardness is your metric at the periphery.
But over the pulp, the approach changes completely.
It does, and this terrifies clinicians, especially with teenagers, because their pulp chambers are so huge.
Right. No one wants to cause a carious pulp exposure and condemn the tooth to a root canal.
But being too timid is a disaster. Very soft, flaky dentine must always be removed, no matter how close you are to the pulp.
But what about slightly soft dentine? The leathery stuff. The text says that can actually be retained.
As long as you place a perfectly sealed restoration over it, yes.
How does that work biologically, though? Will the tooth just rot from the inside out?
Well, you have to understand the advancing front of the lesion. The Depis layer of dentine is softened by acid demineralization, but it's not necessarily infected with bacteria yet.
Oh, I see. So it's soft, but not infected.
Right. So if you seal it perfectly with glass ionomer, you cut off the dietary sugars to whatever microscopic bacteria are left.
Starve them out.
Exactly. And the slightly soft dentine has the opportunity to heal, but knowing when to stop drilling requires what the text calls courage.
You really have to rely on tactile feedback.
Yes. You don't use high-speed diamond burrs for deep excavation. You use slow-speed rosehead carbon steel burrs or hand excavators.
Because carbon steel gives you that tactile feedback.
You feel the disease through the handle. Hard scraping means you're safe. Soft flaking means you keep going.
Okay, let me ask a clarifying question for the listener. What if the patient is already experiencing pain from pulpitis? Does that alter the protocol?
Entirely. Spontaneous throbbing pain means the bacterial challenge has breached the pulp.
The nerve is actively dying.
Right. You cannot seal a filling over a dying nerve and expect it to heal. You have to remove all the decay, even if it exposes the pulp, and pivot to elective endodontics.
That makes total sense. So we physically stabilize the teeth, but mechanically removing decay doesn't cure the underlying disease, does it?
It doesn't cure a thing, it just repairs the damage. If you don't correct the oral environment, the restorations will inevitably fail.
Which brings us to the third phase, preventive treatment. Specifically, diet and lifestyle analysis.
It's the single most important preventative procedure.
Wait, what about brushing? Why is the focus so heavily on diet rather than immediately prioritizing aggressive oral hygiene instruction?
Because OHI won't stop active deep caries as effectively as cutting off the sugar. Caries requires dietary sugars, sucrose, glucose, fructose, to feed the acidogenic plaque flora.
And the text notes this patient only has mild gingivitis, meaning his brushing is actually somewhat okay.
Right, but you cannot outbrush a terrible diet. Denying the plaque its sugar is the best way to halt the disease.
But practically, how do you do a diet analysis? You can't just ask a 17-year-old what they ate yesterday.
A 24-hour recall is useless. People's memories are flawed, and honestly, they lie. They'll tell you they only ate broccoli and drank water.
So what's the alternative?
A multi-day diet diary. You have them track everything for 3 or 4 days, including a weekend. And crucially, you have to look at their lifestyle, not just the food.
Because dietary recommendations are useless unless tailored to their specific lifestyle.
Exactly. It's not just about the total volume of sugar, it's the frequency.
Ah, right. Like sipping a sports drink over 5 hours while playing video games.
Yes. That keeps the mouth in a continuous acidic state for 5 hours. The saliva never gets a chance to buffer it.
So you negotiate with them. You tell them, drink the sports drink with dinner in 20 minutes, then switch to water while gaming.
You reduce the acid attack from 5 hours to 20 minutes without completely banning the drink. It's behavioral psychology.
And while you're working on that behavioral change, the text recommends weekly fluoride rinses.
Yes, as long as the diet remains unsafe, the fluoride rinse provides an external chemical buffer to help remineralize the enamel.
That is such a comprehensive roadmap. We've gone from the illusions of hidden caries to emergency triage, the tactile art of drilling, and finally, behavioral psychology.
It really requires you to utilize every single clinical skill you have.
It really does. And I want to leave you, the listener, with a provocative thought to mull over. The ultimate long-term success of your most complex mechanical and endodontic skills, all of it, rests entirely on your ability to force the patient to acknowledge their own responsibility in preventing their disease.
If they don't change their habits, your best fillings are just temporary patches.
Exactly. For more dental examination prep tips and clinical deep dives, please subscribe and share this episode.